I'm Howard Chansky. I'm the chair of the Department of Orthopedic Surgery and Sports Medicine at the University of Washington, and welcome to our April Grand Rounds. We're very fortunate today to have a talk that is entitled More Than a Bone to Pick, Building Environments of Equity and Justice. And this was put together by Fermin Prieto, who is one of our PGY4s, who will be doing a total joint fellowship after he graduates. This was a topic that was near and dear to Fermin, and he chose Edwin Lindo, who's a lawyer and assistant dean in social and health justice in our Office of Healthcare Equity. So I'm very grateful for Mr. Lindo and Dr. Prieto to join us today and put this talk together. An important talk, as you might all imagine.
Morning, everyone. Thanks, Dr. Chansky, for the introduction. And thank you to Professor Edwin Lindo for accepting this invitation and for taking the time to come and speak to our department. So I actually first reached out to Dr. Lindo at the end of 2024 to invite him to be our Grand Round speaker. And clearly a lot has changed in the last few months. So I believe now more than ever, it's very important to continue to have these conversations surrounding equity and justice. So I'm really honored to be introducing this important topic and excited to hear from an expert in the field. For those of you that don't know me, my name is Fermin Prieto. I'm currently a PGY4 here in the department, and I'm excited to be doing this presentation. So no relevant disclosures, although I would like to disclose that I'm by no means an expert on this topic, simply an orthopedic resident, cares about his education, the education of his peers, and taking care of my patients, and with a path that's perhaps what we will call non-traditional, although I think where we end up is kind of where we choose our own path. So I think it's just been important to me, as I've been really grateful to be this opportunity and to be here today. So to start, why are we even talking about this? The question that I'll continue to bring up during this introduction is, why are we talking about this topic? Why are we doing a Grand Rounds in 2025 about these important topics? So I think while the answer maybe seem obvious to many here, it may be a legitimate question that many of us have, as we have our training modules and more of these sessions, and we continue to have this conversation. So why do we talk about this? So I think clearly it's important for our leadership and faculty to take the time out of our busy days to learn about this. But it also seems to be important for the orthopedic community at large, with many groups and organizations spending a lot of time and resources to ensure this topic is of priority. So I think I like to say, as an orthopedic community, we think this topic is important. A lot of times on these types of talks, we focus on diversity, and we talked about race and gender and the visible types of diversity that we encounter in everyday lives. However, I think it is important to recognize that diversity is obviously multifaceted, and at the end of the day, all these other types of invisible diversity attributes is what really brings that diversity of thought and ideas that we're looking for in a workspace and when we're caring for our patients. However, it's also important to recognize that this is all interconnected, and our race, our gender, how we choose to identify definitely influences our life experiences, our value systems. Hence, I think it's important to talk about all of them. I think additionally, we do talk about these visible diversity categories because they're easier to study, as they can provide more objective data, and therefore we hear more about these labels. So obviously in my introduction, I'll pay some part of that, but I think it's important to kind of go back and look at diversity as a more complex identity. So to answer the question, again, why is it important to talk about this? I think we need to start by looking at the data. I think everyone in this room is aware that orthopedic surgery has remained one of the least diverse medical specialties. So in this illustration, comparing the data from the 2020 US Census and the latest AOS survey of practicing orthopedic surgeons in the US, we know that our orthopedic workforce does not look like the rest of our country and does not look like the makeup of our country when it comes to our patients, with only about 2.2% of practicing orthopedic providers identifying as Hispanic or Latino, and about 1.9% of our providers identifying as Black. It is also not a surprise that our residents are not diverse. Orthopedic surgery has constantly been one of the least diverse specialties when it comes to percentage of women in the field. The latest data from the ACGME, which is published from 2023, only 22.4% of active orthopedic residents are female. And as you can see in this illustration, we are always towards the bottom compared to all other specialties. And once again, when it comes to racial and ethnic underrepresented minorities, we continue to be one of the least diverse specialties. Again, I present this data, and I think everyone here has seen this type of data before in the past, and I don't think it's really a surprise to anyone in the audience, with the exception of perhaps Professor Lindo. But the question still remains, why care about these metrics? Why care about these numbers? Well, I don't think these are just numbers or quotas that have to be met. But the reality is that these represent individuals that sit among us, individuals that we interact with in every day, in our practices, in our work, even outside of work and in life. And it is well studied that trainees that identify as underrepresented minorities still suffer from discrimination, abuse, and harassment in the workplace, which can have a significant impact on their performance and their well-being. We recently had an excellent workshop led by our faculty, Dr. Kennedy and Dr. Tatesman, with the goals of promoting understanding of health disparities in orthopedic surgery and exploring concepts such as microaggressions, implicit bias, and systemic barriers. And this was a really great workshop, and we discussed different scenarios. This is one of them, and I'll quickly read it for everyone. So the scenario was, you're a female junior resident on orthopedic trauma call. The ED consults you on a 53-year-old male after an MVC with a right hip fracture dislocation with small posterior wall acetabular fracture. There is diminished sensation over the lateral aspect of the leg and the dorsal foot. He's otherwise uninjured, but is in a lot of pain. You have done ED hip reductions in the past, and your chief resident, who's also a female, has done several. It's 3 a.m. in the morning, and you approach the ED attending to request sedation for a reduction in the ED. After looking you up and down, he says that the ED is just busy and he's not sure you'll be able to get the reduction. So he wants to wait for the next resident in the morning. Well, this specific scenario is fictitious for the purposes of the workshop that I borrow from, again, Dr. Kennedy and Dr. Tatesman. I have witnessed and have heard about these exact experiences, almost word for word, happen to my colleagues, and not on an infrequent basis. So yes, these issues still do affect our daily works in 2025. So given that these topics are not new, we've been hearing from this for many years, now have significantly been studied, more and more literature is coming out every year with regards to this topic, and there have been active efforts to increase diversity in the orthopedic workforce. Have we moved the needle? Well, the answer is yes and no. In the last 2 decades, female residents in orthopedic surgery have increased from only about 10.1% in the early 2000s to 19.3% in 2020. While this is definitely an improvement, and I think if we continue at this rate, it will take an additional 60 years maybe for trainees to look like our general population. So we're making progress, obviously not quite there. So again, the question is, why do we see this phenomenon? Why and what are those strategies to continue to foster an inclusive environment? So I think obviously these are complex questions. I definitely don't have more insight than I think most of us here, and but I do hope that by doing these types of talks and continue to have these conversations, it will continue to spark interest in continuing to move the needle forward. But unfortunately, when it comes to underrepresented racial and ethnic minorities, we can't say the same. We have seen an stagnant trend over the last few decades, particularly when it comes to Black, Hispanic, and Native American groups in orthopedic residency. And again, compared to other surgical subspecialties, we have not made much progress. So the question again is, why are we talking about this? I think part of the answer, and what I've just going over and doing this presentation and looking at the data, it's because I think everyone in this room would agree that we want to have trainees that are able to perform their best of their ability and in a safe environment and one that is conducive towards learning and growth. So I don't think that comes to a surprise, and yet we have experiences such as the scenario that I presented. So we're also talking about this because we know that healthcare disparities have been widely studied, and gaps in care based on socioeconomic status, race, ethnicity, gender, sexual orientation, and even zip code have been identified, even here in the United States, first world economic power. I grew up in Mexico, and when I came to the States, I saw this as the land of opportunity, the land of unlimited resources. But obviously, it's not the case, and we still see these disparities in a country that has a lot of resources and that spends a lot of money in healthcare. One example that is close to all of us here in the room is demonstrated in this systematic review. It's published in 2024 in Core. They included 14 studies that address racial and ethnic variations in mindsets towards discretionary musculoskeletal care, and it included a total of over 8,000 patients. In general, they found that self-identified Black and Hispanic patients had a lower preference for hip and knee arthroplasty than self-identified white patients. Black patients were also more likely to regard osteoarthritis as a natural and irremediable part of aging and preferred home remedies. Both Black and Hispanic patients value support from religion and were relatively cost-conscious. And Black and Hispanic patients had lower perception of benefit when they were less familiar with the procedure, and they had higher levels of fear regarding surgery and recovery, and they had more limited trust in care. So in this day and age, when we already have a limited trust in the overall population, we know that certain populations have even less from historical events that have transpired in this country. But we are taking care of these patients every day, and I believe it's really our responsibility to understand these factors in order to attempt to improve trust so that all patients are comfortable, both in opting in and as well as opting out of what we recommend for their care. There are many more examples in the literature, obviously, regarding health disparities in orthopedic surgery and obviously in medicine in general. So we get the point. This is important. And I think when we're also talking about this because we care about our patients. I think probably one of our number one priorities in our lives, in our professions, is to take care of our patients and to do it to the best of our ability. The field of orthopedic surgery is definitely inherently interconnected with the diversity of the community. At the end of the day, the goal of orthopedic surgery is to reduce pain, to restore function, improve quality of life, and that last point, improving quality of life, is highly dependent on individuals' own experiences, their culture, their personal values, which are extremely diverse and unique. And so many of the times we have difficulty as providers comprehending these. And many studies have shown that a diverse orthopedic workforce enhances the quality of care, fosters better communication, cultural competency, and ultimately more equitable access to care, leading to improved patient outcomes and satisfaction. So in summary, why are we talking about this today? Well, I think these are more than enough, but I'm sure if I keep digging, we can find more reasons why. But it's still in 2025, we still have a lot of questions. And how do we get there? And how do we make this relevant and important for everyone, really? Because I think everyone, at the end of the day, forms part of the team and our community. So I'm really excited to hear from Professor Lindo on why this matters and how, on an individual as well as on a systemic level, can make the best impact on our colleagues and patients. So with that being said, I'm honored to welcome our speaker for today, Grand Rounds, Associate Teaching Professor Edwin Lindo. He has embarked on the journey to ask and explore the hard questions of race and racism within the institutions of medicine and law and how they informed society more broadly. Professor Lindo brings the interdisciplinary study of critical race theory, LACRID, and community organizing to medicine and law so that we can better learn of how racism detrimentally affects our health, our learning, our teaching, and justice. As faculty in the Department of Family Medicine, adjunct faculty of the Department of Bioethics and Humanities, UW School of Law, and Morehouse School of Medicine, Professor Lindo has published, taught, and developed curriculum on critical race theory and medicine, and to provide students and faculty development around the issues of race and equity in medical education, patient care, and research. Most recently, Professor Lindo has become appointed faculty for the Weizmann Institute a nationally recognized research and education organization. Professor Lindo currently serves as the Assistant Dean for Social and Health Justice within the Office of Healthcare Equity at the University of Washington School of Medicine. His research and scholarship have focused on the history of racialized medicine, race and racism within medicine, social justice, social movements, and decolonized pedagogies for critical education. Professor Lindo is also the creator of the host of the Praxis podcast. This is a podcast focused on addressing racism within medicine and law in all its forms. So lastly, he's an international recognized speaker and thinker on these critical issues. So please help me welcome Professor Edwin Lindo.
Thank you, Dr. Prieto, Dr. Chansky, the department. This is great. I haven't spoken to you all, but some of you have probably seen some of my talks who have seen a talk of mine before. I promise this will be different, slightly different. What's really interesting is I've probably done my talk over 670 times in the last 10 years. It's been a lot of presentations. And each time, people keep coming back because they say, Edwin, I'm learning something new or different each time. And so today, it's going to be a lot more pictures, a lot more conversation, a lot more digging into the issues, because what Dr. Prieto did is laid out the data. It's there. And I sit there and I feel and I understand why some folks would say, so what? So what? Why does it matter? Don't you see our current environment, Edwin? Everything is crumbling down on DEI. Let's get rid of it and let's focus on meritocracy. Well, we'll have that conversation because we can't understand the discussion of meritocracy if we don't understand the building blocks that got us to this particular moment in history. And that gets interesting. So I am not going to talk about orthopedic surgery in any specific way. I'm actually going to take us into the history books of this country, how those elements have led us to today, and hopefully collectively think through what possible solutions might exist. That being said, I also want to highlight, you've heard that I am a critical race theory scholar. I don't hide from that, but I'm sure some folks have heard it again in this particular political moment. And people say, Edwin, I didn't know you could still be that. How do you do that? Are you sure you want to be called that? And what I want to acknowledge is there is no such thing as an illegal idea. That's not a thing. Ideas are what we're supposed to exchange, what we're supposed to battle with, what we're willing to put on the table and say, Edwin, I don't agree with you. Good. Say it out loud. Say it proudly. But unfortunately, we've gotten to a place that folks aren't proud enough to be willing to engage in those disagreement of ideas. And so what I ask folks, and there have been moments that people hear my talks well before 2025, and not that they don't like it. I don't have an issue with that. Actually, those are the folks who I care most about because they care enough and feel enough to disagree. But they're not willing to engage the ideas. The attack tends to be on the individual, the person, the fallacies of, well, I don't like you and what you're doing. And I've heard in all its different forms and fashion. So what I ask, if folks have a disagreement, is for you to pose it as an inquiry of how maybe there could be clarity from someone who has a bit of expertise in this field. And then additionally, if we can engage in a dialogue that gets us to a place of further understanding. I'm not here, as you'll find out, as some would claim me to be as a critical race scholar. I'm not an indoctrinator of second graders. I am not an enemy of the state, though some may claim that. I'm someone who has done the work, just as you all have, to deeply understand the environments that we live in, why they work the way they work. How have we gotten to where we are today? And I think why I've solidified myself in this particular institution and in medicine more generally, because that's another question I get, is that I did the work to understand how all of this seeps into our practice. And just like you all, if a family doc, my colleagues, saw someone who had a fractured femur, you would be terrified if they said, you know what, I'm going to give this a try. I think I can do this. I went to med school. I have some basic knowledge. Let me try to do the surgery to help this patient out. No, they do what? They get a consult. They pick the phone up. They say, Howard, or maybe my wife. I don't know, Howard, if you know my wife, Dr. Estelle Williams. Yeah, she said, if you don't like my talk, you're gonna have to deal with her. But she reminds me, she said, Edwin, I have a very linear focus. I'm a general surgeon. And if there's something outside of that, I don't try to pose as though somehow I know the answer. I go and find the answer. That's what we've been taught in medical school. Let's find the right answer. And what I'm suggesting is I've been able to present and offer a place where folks get to pick up the phone, and it happens quite a bit. Edwin, there's this situation with the patient, and I don't feel like I'm either communicating with them well, or they seem to have a struggle with the care that we're providing. And it's not like they're asking me for expertise in clinical care. They're asking me, Edwin, can I better understand how to approach this patient, to understand this patient? And we're actually rolling out at Harborview very soon, and 9 and 8 East, an equity consult service. Very similar to an ethics consult, but even ethics calls us up and says, this is definitely fallen outside of our scope. We need some guidance and support to understand the inequities that may be ruminating in this scenario. Could you help us? And so what we're seeing is it's no longer a discussion about, oh, it's an idea that sits outside of the canon of medicine, but actually it's a practice that helps us provide better medicine and better care. So I want to lay that out as a preface. I also have no issue with you interrupting my talk. You can't interrupt it. It's learning. We're doing it together. So if you have a question, raise your hand, say it out loud, and we'll discuss it. I am unlike many of your colleagues and perhaps the professors you had. They say, Edwin, I have to get through these slides. I don't have to get through these slides. These are going to be things that guide us, but I am not beholden to these slides at all. I have no conflicts, nor do I have any money. So you don't have to worry about that. I think a good place for us to start is, because we've said this word a lot. It's in my introduction. It's mentioned, this word racism. But it's really important for us to start from a basic understanding of what that means, at least again, from my perspective, so we can have common knowledge. When we talk about racism, and there's gaps here, the slides keep doing that. It's a belief that race, I'm filling in the gaps, that race is the primary determinant of human traits and capacities, and that racial differences produce an inherent superiority of a particular race. This was found in the Oxford and just about every other dictionary in the world up until 2020. It's interesting because we don't necessarily understand racism to be that, at least not today in many aspects. But that's how it was viewed. It was, if you believe that your race is superior to someone else, that's racism. The function of that, the struggle I have, is the operative word belief. If we're saying that only belief is a prerequisite to racism, well then shoot, everyone, we're all racists if you just believe it. But there's no necessary of action or power or ability to further these beliefs. It's just if you have the belief. And that wasn't sufficient. It wasn't meeting the standards of us understanding how racism works in our society at large. And so in 2020, that definition has changed to now, and I'm paraphrasing, this has been a definition that many folks in social science have used. It's an understanding of systemic power as an element of racism. That is, that it's systemic power plus prejudice, prejudice being the belief. We all have prejudices of one form or another, but not all of us have the power to effectuate those prejudices. That's where a subtle but very important difference starts to arise. Power being the possession of control, authority, or influence over others based on your identity or situational placement in society. The prejudice being an irrational attitude of directed against an individual of hostility directed against an individual, a group, a race, or those supposed characteristics. Again, a belief, a prejudice. I don't care if someone believes that I don't know, I'm dumb because of the race of my skin. I don't care if they think I'm a spick, which I've been called before. I don't care if they call me a wetback. I don't care that their belief is bigoted because their belief doesn't have a material effect on me. I'm trying to get to why this definition is important. The moment they have the authority to effectuate that belief, now we have a problem. Because now we're talking about that person's belief towards me can have a detrimental effect on my outcomes, even if they never say those beliefs out loud. Skipped it. There we go. Oh, I keep wanting to move. Sorry, I'm going to stay right here. It's important for us, if we're going to talk about race, we're going to talk about racism, to really have a stronghold of the beginnings of this concept of race. Carl Linnaeus, many of us are familiar with Carl. In your 10th grade biology class, when you named all the flora and wild animals that existed in the world, Carl named them. Carl was really good at naming things. And for most part, the names continue on. And I'm not here to try to throw away Carl and say we should rename everything because Carl Linnaeus is the one who named them. No, what I'm saying is this individual had significant amount of scientific power. At some point said, geez, I'm really good at naming these things. I think I should also try to name and categorize human beings. A point I want to make is that oftentimes we think that medicine is apolitical, free of politics. We're just here to provide care. Carl Linnaeus was a biologist and a Swedish physician who cared for other human beings. He could have stopped at naming the wild animals and flora, but he didn't. He said, there's differences amongst us. The question I have, because he essentially said, I have a research question that I want to answer. The question I have is, why was there an answer needed for that question? Because he believed that people of different races were of a different species, which is absolutely wild. Because in that same 10th grade biology class that I was referring to, what do we remember of things that are of a different species? They are unable to what? Procreate, have children. Well, then that thesis is out the window. It was called, excuse me, mine is slipping me. It was called polygenesis. There was a cadre of scientists during the late 1700s up until the 1860s that were referred to themselves as polygenicists, that believed that people of different races came from different origins. And you say, so what, Edwin? It doesn't matter. We're in 2025. What I'm trying to establish as my hypothesis today, and for much of my work, is that the racism, the scaffolding of inequities that we see today across the board of the different forms of isms that exist in the world, it was created by the mechanisms of scientific medical research. Okay, Edwin, now you're attacking medicine. And I've had colleagues that stood up and say, Edwin, how dare you suggest that medicine had any role in this racism that you're talking about? I'm not saying it. He said it. What did he say about Asian folks? He said they were yellow, melancholic, stiff, black hair, dark eyes, severe, haughty, greedy, covered with loose clothing and ruled by opinions. It sounds terrible to say it out loud in 2025. I know that. He says of Native folks that they're red, choleric, righteous, black, straight, thick hair, stubborn, zealous, free, painting himself with red lines and regulated by customs. Now, mind you, he never actually met these people. He asked explorers to make paintings. And mind you, yes, there was no technology of any really sort. And so he asked them to make paintings to bring back to him that he would observe and then make his scientific observations off of. And this is what he decided those observations should be. He says, for Black folks of the African continent, that they're Black, phlegmatic, relaxed, Black frizzled hair, silky skin, flat nose, tumid lips, females without shame, mammary glands give milk abundantly, crafty, sly, lazy, cunning, lustful, careless, anoints himself with grease and governed by caprice. What does he then say of Europeans? It is an awfully positive inclination. He says that they're white, sanguine, browny, with abundant long hair, blue eyes, gentle, acute, inventive, covered with closed vestments and governed by laws. Again, so what, Edwin? So what? Has no relevance to us today. The scary part is that it does. The scary part is that it does because these are stereotypes that I've heard today in 2025. You just have to go on Twitter or X or whatever they call it, and you will find some of the ugliest, most vile things you can imagine. And I've read these things. And what Carl Linnaeus did here is threefold. First time in a scientific published piece that color was used as a descriptor of human beings to be a form of associated value. He's not saying that it's who they are physiologically, not yet, we'll get there, but he's saying that they have a color and is now published as a scientific fact. These colors were made up. There was no scientific color numbering. He didn't use the color from Sherwin-Williams. He just made them up. He then gets into his physiological observations, right, of the phenotypical expressions. But then he does something even more interesting. After each one, at the end of each one, he discusses what? He discusses very non-physiological things, as though he was a sociologist. Carl Linnaeus is not a sociologist, not by a long shot. He never claimed to be. He also never did this with animals, which is also very interesting because it means that he had an intentional force and need to create distinction here. He could have done it with wolves. Apparently, they say wolves go in pack, though it's been, there's science that suggests that what we suggest they do is not true. But he could have observed the culture of different types of animals, but he didn't. He did that of human beings. And why is because he's already beginning the racial hierarchy, the racial taxonomy of differentiation. And if color wasn't sufficient and the outward presentation of one's bodies wasn't sufficient, he then said, I'm going to tell you how else we're different. We wear clothes, they don't. We are governed by laws, they are not. And if you're not governed by laws, even if you meet every other element, you still can't fall under that category. That's important because we're having, again, very similar conversations today of who is a savage, who comes from a certain part of the world, and who is welcomed to be, quote unquote, American. Samuel Morton said, Carl, you just didn't go far enough. I needed to go further. I am also a polygenicist, but you weren't racist enough. Caucasians are, quote, distinguished by the facility with which it attains the highest intellectual endowments. And that Native Americans are, quote, averse to cultivation and slow in acquiring knowledge, restless, revengeful, and fond of war, and wholly destitute of maritime adventure. And of Black folks, he says, quote, the Negro joyous, flexible, and indolent, while the many nations which compose this race present a singular diversity of intellectual character, of which the far extreme is the lowest grade of humanity. This is wild stuff. And some would even say, Edwin, see, this is what you CRT critical race scholars do. You're just out here to be a victim. I'm not a victim. These are facts of history. I'm explaining what took place in the beginnings of the foundations of what we would identify as Western medicine in the United States. Samuel Morton was also the one who did the cranial studies of what humans had greater cranial capacity than others. And his belief was if you had a larger cranium, you were more intelligent than someone who did not. And it just so happens that according to his data, it was Europeans that on average always had the greatest cranial volume. Though when you research his research, the way he did that study is he literally put ads in newspapers and asked people to send craniums to him and put his address and said, please just note the name, the age, and the ethnicity of this individual. Folks were just making stuff up and sending things in. He had no way to confirm who or what they actually were. He was just getting skulls in his lab. If we don't ask these questions, we would assume, well, there's real science out here, Edwin. But also I want to identify, it's not the victimhood. I'm not trying to be a victim. I'm perfectly fine. I went to law school. I've worked at Microsoft. I'm good. I'm trying to have us figure out why in the world is it still happening today? And if we try to figure it out in 2025, we won't get there. Because like a building that we try to implode, like an old stadium, you have a structural engineer that comes and you ask them, where should we put the dynamite? Between these two options, where do you think you would choose or she would choose? At the roof of the stadium or at the foundation of the stadium? At the foundation. It would be silly to put it on the roof. You would just blow the roof off and you would still have an entire building left. And what my work is trying to get into these crevices to understand how and why. And again, furthering my hypothesis, saying that medicine had an integral, if not an architectural role in the inequities that we see today. It's because it laid the medical foundation of how we said it was okay to not like and be bigoted towards other human beings. What do I mean? How? If we think and take Jim Crow era South in the United States, the segregation was you couldn't sit on the same bus, you couldn't go to the same school, you couldn't eat at the same countertop, you weren't allowed to swim in the same pool, you weren't allowed to live in the same neighborhood. That was a very intentional and interesting form of racism. Because racism could take the form of not separating yourselves from other human beings. It could be, I just don't believe you're equal to me. Sure, you can sit here. I just don't think we're the same. You are inferior to me. But we can all be in the same room. So why in the world would you separate yourself from another human being? Because you believe that they are not only socially, but physically, biologically, and intellectually inferior. And you can't establish that as a society in isolation. You do it because medicine told us that it was okay to do that. Because they told us we were different. And if medicine says it's true, then it ultimately is. And then Samuel Cartwright not only said, let's take it even a step further. He said, I'm going to use it in my practice as a plantation owner. Samuel Cartwright, a physician, a surgeon, psychiatrist. At that time, you were able to do both. Studied under Benjamin Rush, was a professor at Harvard. He also owned over 60 enslaved Black folks. And he came up with two pseudo-diseases, psychiatric pseudo-diseases. The first being drapetomania. And what he said in his observations of the enslaved people that he owned was that any person who ran away from slavery to seek freedom had clinically lost their mind. I'm paraphrasing, but that's what he meant. And that the way that you fix it, as you can see, is corporal punishment. I know, I am absolutely a downer, especially at 7 in the morning. I get it. But I will say what's really interesting is that I'm getting beat every day by someone who is in an Oval Office. And so like this actually, this is not bad at 7 a.m. I usually feel really bad saying like, I'm going to have to show you some really terrible things. But this morning, even just coming in, I said, okay, well, this might be an uplift for the orthopedic surgery department. He then goes on to create a psychiatric disease called rascality. He says that from the careless movements of the individuals affected with the complaint, they are apt to do much mischief, which appears as if intentional, but is mostly owing to the stupidness of mind and insensibility of the nerves induced by the disease. I emphasized insensibility of the nerves. What does that mean? What is insensibility of the nerves?
They allude to the fact that you can't experience pain like they're.
Correct. You don't feel pain. You would say, okay, Edwin, that's fine. 1851, he wrote in his report, I'm glad we don't have to deal with it anymore. Clearly, this was disproven. It's not real. Well, interestingly enough, it's still on the New England Journal of Surgery and Medicine. It was never, quote, disproven, because we know how medical research works, is you then need to do a study to disprove the study that was done. And so how do you do a study to disprove a thing that's not real? Secondly, in 2024, there have been studies that show that Black and Latino patients receive differential pain management for the exact same pain levels on the exact same floors in the exact same hospitals. It's because there's a belief that they don't feel pain. No, Edwin, that's not it. There's other reasons. I've never heard anywhere in my medical education, in my training, no attending has ever said, Edwin, we treat people differently because of the color of their skin. No, I've never seen it either. I've looked at every piece of material in our medical education at UW, and it doesn't say it. I've asked residents from across the disciplines, has anyone ever said that Black people feel less pain? No, never heard it. Then why does it still happen? Because we don't have to say it anymore. It is so ingrained that it's no longer an open invitation that we have to show this expression of disdain or hatred or bigotry. It is now a practice in the culture. And it doesn't take the form of, again, of race, but ways I have heard it is, Edwin, I've seen these kind of patients before. They're drug seeking. This is a drug seeking patient. And you may not be wrong. What I'm asking is, can we take a moment and pause and ask, is that the reason we are providing different pain management for this patient? Because if we don't, we are going to lead ourselves to exact same inequities that I just mentioned. All right, so now we're going to get into the history if we haven't already. I want to note this date, 1863, Samuel Cartwright died. 1863, January 14th, is the same day that the Emancipation Proclamation was signed into effect. Emancipation Proclamation did what? You can say it louder. I swear I'm not going to scream at you.
Ended slavery.
It ended slavery. And then followed the 13th Amendment as a result of Emancipation Proclamation, January 14th, 1863, 13th Amendment, 1865. You say, Edwin, why in the world are we looking at the 13th Amendment? Because what I also want to show is how the racism that was inculcated in these foundational elements of medicine have found their way to just about every crevice of our society. And here's one big one. What does the 13th Amendment say? It's not a trick question. My law students don't even know what it says because most of the time, no one has ever had to look at the Constitution. You might have now in January 2025, but what does the 13th Amendment say? It's hard to read. I didn't mean for you to read it here, but I did put it up there in the white. I'll read it for us. I see this as shy group, which I was told you were not shy. That there's a lot of talking that happens in that OR. Quote, neither slavery nor involuntary servitude, except as a punishment for crime whereof the parties shall have been duly convicted, shall exist within the United States or any place subject to their jurisdiction. What does that mean? Correct. That the freedom and the prohibition of slavery has an exception. I'm going to say that again. There is an exception to slavery in the United States of America. And it is if you are, quote, duly convicted of a crime. We have over 2 million people in jails and prisons in the United States. 2 million. Which suggests that there are over 2 million people that are property of the state. And if you're a property of the state, it means now that you don't have authority or autonomy of your own body. That we arguably have over 2 million enslaved people. Response, valid response. Edwin, but they're criminals. We've been hearing that word a lot, but they're criminals. Okay. Does criminality then mean that a country has the right to put you in slavery? That's a question you will have to answer as a personal one. I personally don't believe that should be the case. Well, Edwin, that's not really slavery. They go outside and they have work programs and there's opportunities to do things. Of the top 20 Fortune 20 companies, every single one of them uses prison labor. And in prison, there is no minimum wage. You've lost that right. You've also lost the right, if you're a felon, to vote. You also often lose the times to get housing. And in many places outside of this state in California, you are very unlikely to get a job. Okay. So if we're saying 2 million people could potentially be put to work, they do get paid, and that's what's really interesting. They get paid between 40 cents to $1.25 an hour. 50% of your customer service calls are answered by folks that are in prison. 60% of government products that are made, from helmet and protective items for government entities to use, made in prison. Furniture, and many furniture making companies are made in prison. There is now a campaign, and Oregon, interestingly enough, just passed a constitutional amendment last year to eliminate the exception of the 13th Amendment that exists in their state constitution. That is very interesting. The other point I want to make where this gets even more fascinating, and Dr. Prieto, if you can just keep me track on time so I don't lose it. I go till 7.
At 8 o'clock, we might start getting tickets for parking out.
Yep.
You can go as long as you want, but probably we should wrap it up by 8. So.
Yeah, that's easy. Perfect. The other part of prison population.
I should just say people may have to leave and go to the OR clinic, so
yeah,
you guys have to do your jobs, and that's okay too.
You do. I am not offended if you get up and leave. Other interesting point is that the way the prison populations work is that wherever a prisoner is placed, they now become a resident of that district. Where do you think the majority of our prisons exist? In the most rural areas of this country, which means there's an increase in representative power in the National Congress. Think about that. And I don't need to get into the racial inequities that exist in prisons, but we're talking about overwhelmingly Black, Native American folks that are incarcerated, disproportionately, almost to a factor of 5. Yeah,
So almost 500,000 of your 2 million incarcerated were not convicted. What's the duration that people
Ooh.
ever spend in jail not convicted?
Good question. We're talking about between a week to up to 3 years. And some may say, wait, how are you in prison and not convicted? It is pending charges. So there have been no charges filed yet. And you are sitting there waiting. Yes. And it varies a ton. Correct. Can you afford a private attorney to advocate, to file a motion? If you can't, you're waiting for the public defender to get through their caseload to be able to get to your case and advocate. Great questions. In Seattle, you may be familiar, but we had redlining in Seattle up until the mid-1970s. Redlining being that you were not allowed to live north of Madison Avenue if you were of a certain ethnic or racial descent. This is a deed from a house of a friend that I know. And if you read clause number 4, this is 1946. This said property shall not be resold, leased, rented, or occupied except to or by a person of the Aryan race. That means no Jews. That means no Asian folks. That means no Black folks. We are not that far from this. It has seethed its way into spaces that are forcing outcomes that we think are just natural causes of our environment, when in reality, they were structurally in place to create these inequities. And what do I mean by that? Let's quickly go to COVID. 2020, March hits us. We are hit with the load of sick people coming into our hospitals. We run out of, what was the special machine that we ran out of? The ventilators. That the state health board had to get together and say, how are we going to allocate this scarce resource? And they came up with an equation. And they said, we're going to look at expected longevity of life if they get this life-saving device. If you have a pre-existing respiratory disease, your value will go down in this equation. Less likely to get the ventilator. Redlining 1940 to 1970, you couldn't live north of Madison Avenue. You had to live south. We're talking about White Center, Soto, Georgetown, Beacon Hill. Take a guess where the highest rates of respiratory disease exist in Seattle. South Seattle. We're talking about by a factor of 3. Kids in Seattle are almost born with asthma because of where the freeways and the truck stops and the particulates falling into the backyard and the playgrounds. Okay, well, that 3-year-old, who in 2020 is now 21 years old, goes to the hospital with a respiratory disease, and they're told they can't get a ventilator. And it wasn't their fault. They just happened to grow up in a zip code that said you are 3 times more likely to get asthma than anyone else in this entire city. That's how structural, durable racism impacts the care and the health of our communities. We look at appraisals of homes. This home, there's a video, but I won't show it. A Black couple had their home. They have Black art, books with Black authors. They have their pictures of their families. An appraiser comes and appraises their home in Marin County, in the Bay Area. They bought the home for $1.4 million. It was appraised at $970,000. And they were like, how did we lose money? We just put $300,000 in equity in it, remodeling. They appealed it. The bank agreed to do another appraisal. Second appraisal came, but before they did, and mind you, it was both white appraisers, Before the second came, they asked her white colleague if they would pretend that this house was theirs. They took all the art away. They took their family pictures away. They told their kids they're going to go to Starbucks for the next hour and a half to wait for their friend to fix the house up. The house was valued at $550,000 more. 2 weeks later. Same thing happened here in Seattle and Columbia City. It happened to me and my wife, who was a Black female surgeon. I'm a dean. We go to the bank. We say we'd like to get a physician loan. They said, sure, but you're going to need 6 months of reserves in your bank account. If you've ever bought a house, having 6 months in reserves in your bank account is absolutely wild. I might as well just pay for the house cash. They then said, your wife seems to, and they met both of us in their office. Your wife seems to get a very large influx of funds into her bank account every month. And I know you gave us her contract and her pay stubs, but can you get a letter from the chair of the department saying that this is where it's coming from? Excuse me? And I was blown. I get mad. We call up the chief people officer and we said, we just have to let you know what's going on. And in 27 minutes, we get a call back from the loan officer and they said, Mr. Lindo, I'm so sorry. I misread our policies. You only need 2 months of reserves. And I don't need that letter anymore. Imagine if someone didn't call. Imagine if someone didn't fight. And this is where we say that it is more expensive to be minoritized in a society that gears towards a certain place. What else does it look like? Where else has it seeped its head? In third grade classes, you may have seen this. It was PBS, our public television, that is also being scrapped and unfunded. There was a teacher, Jane Elliott, in 1968, the day after Dr. King was assassinated, she did an experiment with her students that would no longer be ethically allowed today. She sat them down in a room, and it was an all-white town and an all-white class. And she said, I have these blue little collars. She said, I have these blue little collars that I'm going to put around the brown-eyed kids in our class. Why? Because brown-eyed kids are not as intelligent. Their parents hit them. And they're just all around not good people. And this is at 8:30 in the morning. She puts it on, and then she reinforces what she just said. She said, Billy, did you tell me that your dad spanked you yesterday? And he proudly said, third grader, yeah, he did. Why'd he spank you? Because I jumped off the roof of our house. And he said, so your dad hits you, and you do wild, silly things all the time, don't you? I said, yeah. Johnny, why do you think that is? Because he's brown-eyed. And then she said, brown-eyed kids have to wait till the blue-eyed kids go outside to playground for recess. You get 30 minutes where the blue-eyed gets 45 minutes. Blue-eyed get seconds during lunch, and brown-eyed can only have half their plate. In 6 hours, she made these blue-eyed students some of the most bigoted, hateful individuals you could ever imagine. Where on the playground during recess, there was a fight between a blue-eyed and a brown-eyed child. And when she asked the brown-eyed, why did you punch Johnny in the face? And the brown-eyed kid said, because he called me brown-eyed. And now all of a sudden, brown-eyed became a derogatory word. Because the system conditioned the entire environment to believe that one person was better than the other. She then showed the intellectual effect of it. At the end of class, she circled up the brown-eyed and the blue-eyed kids and had them do their multiplications and timed them. And they had been doing this for weeks. They were skilled, they were equipped. But the brown-eyed students did it slower than the blue-eyed, substantially slower. And she said, why can't you get it as quickly as the blue-eyed? And they said, we're just not as smart as them. And the blue-eyed said, it's because we're smarter than the brown-eyeds. Insane. But then she said, I'm going to prove it again. And the next day she switched roles and did the whole thing again. But now the blue-eyes were the ones who were less intelligent, and the exact same results happened. Now imagine 350 years of conditioning a society to believe that people are different because of the color of their skin, intellectually, socially, and physically. It even exists in our film photography and what we used to watch on television. I'm gonna say we used to watch. Some of you may not be old enough, but there was like a knob that used to click and you had antennas and you would put a hanger, a wire hanger on it to get the signal. And I do film photography, and this was very peculiar to me. But the emulsion on the film that's created was tested to make sure that white skin was viewed in a pristine light on television, which ultimately had the consequence of Black folks wouldn't be viewed. That's why they're overly saturated on television and looked much darker, because it was never intended to show them in the best possible light. It was intended to show this skin in the most positive light. Again, not accidental. Then we get to the medical components. We have the pulse oximeter. You're probably familiar with the consequences of the pulse oximeter. I know we still use it. It's important. I'm working with our bioengineering folks, but the pulse oximeter has misread oxygen levels 3 times worse, or excuse me, 3 times more likely to misread oxygen levels of dark-skinned individuals because of the melanin they have in their skin, because the bioengineers that did the testing never tested it on people with melanin. That's bad science. It has nothing to do with race. Melanin is not some racial thing. It is scientific. And we didn't do the work to ask the right questions. You look at the spirometer. Fascinating story. The person who made the spirometer was Samuel Cartwright. We learned about them earlier today. And he tested his spirometer device on the enslaved people that he owned. And what he found, according to him, was after long days of work, they had the worst lung capacity compared to the white slave owners that were sitting on the porch. And therefore, he, in a research paper, said that Black people, on average, have worse lung capacity than white individuals. And as a result, when emancipation occurred in 1863, life insurance insurance companies, looked at the spirometer and said, oh, Black people have a pre-existing health condition and we will not grant them life insurance. Even more scary is that today, our pulmonary function test, the machine that exists, I don't know if any of you have used it, it still holds the racial exponent that Samuel Cartwright put into it, saying that Black people have differential lung capacity than white folks. The eGFR, renal function. Here at UW, we finally changed the eGFR renal function equation. It used to be CKD epi and MDRD, and it had a racial component to it because a research paper suggested in the late 90s, after studying an N of just 1,175 Black people, that Black people on average have greater muscle mass, and therefore we should account for it in measuring kidney function because of the creatinine serum that gets pushed more efficiently with greater muscle mass. We used that average, created an equation, and applied it to every individual that walked into our clinics. And the exacerbating results of it, what it ultimately did was, if you were Black and you had an African-American number and the non-African-American number, if you were African-American, it showed that you had a healthier kidney than you actually did, because you were supposed to have greater muscle mass. The consequence of that was that Black and Latino folks were having the highest rates of end-stage renal disease. And folks can figure it out, because how in the world can people with healthy kidneys end up with the greatest rates of end-stage renal disease? Because we didn't catch it. And we kept telling folks they were healthy until they were no longer healthy. And so in 2020, working with the team, we eliminated the racial exponent of the eGFR, And we ended up using the CKD epi without race as the more efficient equation. And what we've seen now is the entire bell curve of every single patient we've had at UW. It used to show that Black people's kidneys were more healthy than everyone else's. And now the bell curve is directly on top of each other. Why? Because a kidney is a kidney. It's not a Black kidney. And it's not a white kidney. It's just a kidney. I'm going to pass this. So what are the consequences of racism on everyday life, on individuals? And why is it important that we talk about the diversity of our department? We talk about the diversity of our students. We talk about bringing in care that is reflective not only of the community, and this is not at the expense of white folks. I think some people say, oh, it's stealing opportunities from a certain group. And what I want to get to is that there is no such thing as stealing the opportunity from someone else. When we talk about equity, it also means that we have to examine the disproportionate advantage a community received. I'm going to say that again. If a community received a disproportionate advantage, it means then if we're going to correct it, it's not that folks are getting less than they deserve, it's that they were getting more than they deserve to begin with. And how do we bring everyone up to the starting line? It also then ultimately means that the folks who were disproportionately disadvantaged are getting more care than they were receiving before because they weren't getting it in the first place. Prime example, never have I heard someone get mad that a non-English speaking Spanish person gets a translator. I've never heard an English speaking person get mad that that person gets a translator. They never say, how come I don't have a translator? Because you speak English. That's why. You don't need one. But this individual does to get them to the starting line for us to all have the same conversation, literally. It is, interestingly, disproportionate care. We're giving more resources to this individual who doesn't speak English. And the person who does speak English is not getting more resources as this individual. Is that unfair? I would argue not. It's we're making it equitable. And the consequence of the systemic racism that we've been talking about is you have Dr. Murphy and Braveman that showed that there is a 4.2-year gap between college grads of white college grads versus Black male college grads. And what they found is that that 4.2 years is a testament, because they can't explain, it's held for everything else, economic status, health. And what they found is that the stressors of experiencing the bias and the racism on a continual compounding basis takes years off of people's lives. 4.2 years is a lot of hours and a lot of days. And in doing my research for this, what I found, I came across this blog or piece, you've probably seen it, but it hit me where it says it's called, the orthopedic surgery is called the whitest specialty. And that may sting a few, that may make folks say, geez, maybe, well, I'm white and maybe it is the whitest. I mean, the data shows. It's not a critique of the individuals in it. It's to get to the fundamental question, I believe, of if, and it's also very male, so white male focused. But the question we have to ask is not, oh, do we need to decrease the number of white males in the department? The question we need to ask is, being in this department, if we don't believe that it should only be white males, if let's say we all as a consensus believe that we want a diverse group of residents, then we also have to disabuse ourselves of the belief, because this is why it continues to happen, the belief that only white males are capable of doing this job. I'm going to say it again, because some people say, no, Edwin, I don't believe that. No, it's not whether you're saying it out loud. It's that the conditions that exist is what we're saying when we look at the data that Dr. Prieto showed us, is that we believe that there's only a group of people that can do this job well, if we're talking about meritocracy. Because I've heard a lot, Edwin, we're just choosing the best candidates. Okay, then what we're saying is that the best candidates are only this particular group of people. And I don't know if that's true. I think there's many incredible candidates. The hard question is going to be, how do we choose among the many great candidates? And if we are trying to choose amongst many, how do we make that deciphering factor? Again, it's not race. It's the experiences that people bring and their ability to care for these patients and be a team player and step up when they need to and provide the education and research. So when we talk about building equity, I'm going to run through this quickly. We have to talk about uplifting faculty. No one should feel alone in the department. That means from leadership, Dr. Chansky, to the interns, that folks are feeling, I can say this thing out loud and I'm not going to be reprimanded or my career is not going to end because I either asked the question or said the thing. And that attendings and leadership say, no, you have my support, that you inquiring and asking us to be better is not a thing that you're going to be reprimanded for. So that support, it needs to be there. I'm going to give a quick example. Estelle Williams, my wife, was a resident. There was a patient, a white patient at UWMC that told her when she walked into the room, I asked for my surgeon. And she was like, oh yeah, no, I am your surgeon. And he said, no, you're not. And this is an older white male with views that someone like my wife couldn't be his surgeon. And she said, no, I'm a second-year resident. I am your surgeon. I will be doing your surgery today. And he said, no, you're Black. You're not doing my surgery. She went to her attending. She was very calm, went to her attending and said, it seems like we have an issue. This patient doesn't want to have a surgery done by me. That attending, senior attending, walked into the room, looked at the patient and said, so we have two options here. You could either get your surgery by the best fucking surgeon I've ever known in my life, who is Dr. Williams, or I will be more than happy to call a surrounding hospital and transfer you to someone who's willing to provide you this surgery and that you feel comfortable with. That patient got his life saved by a Black woman, and her name is Dr. Williams. She wouldn't be able to do that if that attending wasn't very clear, wasn't very firm, not disrespectful, not saying, you have to do this. It was, this is how we do things here. And the patient had a choice. And it was for the better that he got that surgery. Equity and recruitment. There is nothing in the policies and the executive orders that have come out that suggest that somehow anything has actually changed. Now, funding for research, that's a material change. We're seeing that in real life. But we live in a state that passed I-200. I-200 in the state of Washington says you cannot discriminate based on race. There is no affirmative action. We have always done that. And we still work to diversify the populations of our communities. And so I don't want us to reel back. I actually want us to stand firm in that there is nothing that we're doing that is illegal. When you go to SNMA, when you go to the National Medical Association, when you go to SBAS, the Society of Black Academic Surgeons, or LMSA, there is nothing illegal about that. We can ask and encourage folks to apply to our departments because we want the most diverse applicant pool possible. Equity and research funding. I put questionable because clearly we are in a state of flux and it is unclear what's going to happen. But there has to be equity in research. And who gets the R1? Who gets to submit the application? Who gets to be on the application? How do we lift folks up who have historically not been in those conversations? Addressing the tax of racism. I talked about racism a lot today, but essentially it's the tax of what my dad told me when I was growing up. Edwin, you're going to have to work twice as hard to get halfway there. That's a tax that I get unpaid for because I do work twice as hard to go half the way, which means that delta between half and twice as hard is uncompensated. And a lot of people are like, Edwin, we all do uncompensated work. It's true. But the legacies of the redlining, the legacies of the chattel slavery means that now me and Estelle have to go back in time and help our families who have absolutely no money. The equity in the care we provide to patients. The I don't see color means I don't see the cultural differences of people who don't look like me. How do we fundamentally change that? I'll skip that. Here are some resources. I want to thank y'all. I know I went over time a bit, and thank you everyone who was online. Dr. Shansky, thank you. Dr. Prieto, I really appreciate being here with y'all.
I know we're out of time. I want to say I think we are quiet because this was so unsettling. I've heard it, several times I've heard you give similar talks, and I think that's a gift for us. It gives us something to go through our day and actually think about really deeply. Yeah, when we all, I think, we're focused on our jobs, sort of getting through the day, dealing with some of the madness that's going on in our country right now. So I feel like you left this the gift. Thank you, Dr. Jansky. Any other questions, thoughts, feelings? Someone asked. Anybody have anything? I'll ask something. Yeah, in the very beginning of your talk, you said, I don't care if somebody calls me a stick. I don't care if they think I'm dumb, as long as they're not impacting my life. I felt that was the gist of it. But when those people are out there feeling that way, you know that eventually it's going to come back to like you. And so I'm just curious, like, how do you deal with that? Because for me, it would make me very angry. I'd want to lash out. I wouldn't be able to sort of have any kind of tech voice. Yeah, that's a good question. And I will say I was never always like that. I would lash, I would respond, I would scream, and I think I still would, but in a different way, in the immediacy. But there's a quote by Toni Morrison, a famous author. I love her work. A black woman who says that racism, or really any other form of ism, any bigotry, is at its core just a distraction. And when I frame it and hold it in that way, she then goes on to say, they used to tell us that we couldn't paint or create beautiful art. So we spent our whole lives trying to prove that we can be artists. They told us that we couldn't write literature. So we spent our whole lives trying to prove that we can write literature. And it hit me eventually that it doesn't matter what I do, they will always continue to believe that. And so how do I remove myself from distractions so that I have the energy to focus on building the communities that I want to build? But it's not easy. And I'm sounding almost very Zen-like, but it has been a lot of work and practice to get there. I have a question from Bowie, Dr. Bowie. And she says, when I was a medical student doing away rotations, I noticed I felt more comfortable at programs in rooms when there were other people who looked like me. That comfort was ultimately one of the reasons I chose this program for residency. If diversity leads to further diversity, how can we help promote it, especially in the current political climate? How can we help promote it in areas where we and other programs lack diversity? Yeah, great question. I think it requires an intentionality of stepping into places that we may not feel comfortable in. I'm going to give example. I'll call out Chair of Surgery, Doug Wood. Doug Wood goes to the Society of Black Academic Surgeon, and he has for quite some time now with Estelle, and I encourage our department chair in family medicine. Let's go to the different groups, because sometimes we say, no, that's their group. That's not for me. I don't want to intrude. And what we're saying is no, us being there is the presence that we care enough to be part of this, to encourage the work that this particular group is doing. And it's varied. It's across the board. But our presence alone, I think, goes a long way. And whether it's a resident or whether it's a fellow, when we're in those spaces, the communications that happen, the relationships that are built, the conversations that are had and I hear it from medical students who are aspiring, and they say, I don't know how to get into your program. Or people say that it's like this, can you really tell me how it is? Or I don't even think I'm qualified for it. And sometimes all it takes is a Dr. Prieto, a Dr. Chansky, or someone else saying, no, you need to apply. I'll review your application before you apply. I'm not going to tell you what to put in it, but I'll review it to provide some guidance. And I don't know if you'll get in, but at the very least, don't say no to yourself before someone else does. It's a small gesture, but the moment we do that, it opens the doors for folks that have the confidence to say, well, I'm gonna give it a shot. And all of a sudden, the applicant pool gears up, and now we have broader, greater choices. We have to wrap it up. Yeah, I want to thank Professional Lindo and also Dr. Prieto. Again, I don't want to embarrass for me, but he's everything you could ever ask for a position in a resident. So thank you, and thank you, thank you. Thank you so much. Good to see everyone. Okay, thanks.